Hello, my name is Farah Deshmukh. I'm a fellowship trained and board certified obesity medicine physician, and I'm also board certified in internal medicine. The common understanding of weight gain and weight loss is that you have to eat less or eat more, you need to exercise, etc. However, the reality is that the way your weight regulation works, whether it's weight gain or weight loss, it's way more complicated than that. Your brain takes input from multiple sources, including your gut hormones and fat cells, and regulates our metabolism. It also regulates our appetite and energy expenditure. In this video, I will discuss some of the key hormones that we need to know for the obesity boards. These are some of the important hormones that you need to know for the exam. You need to know where they are secreted or produced, which I will discuss in another video. Some important points about each one, and when we dive into these specific pathways, their role in regulation of weight or energy expenditure will become more clear. Ghrelin is made in the stomach and its secretion increases with weight loss, which is important to know. And we will talk about the relation of ghrelin and leptin in another video. Ghrelin secretion also increases with stress, and we see that in our patients who are stress eaters. Lack of sleep, which in general causes the level to increase, but also patients with obstructive sleep apnea who are not getting quality sleep, they tend to have higher levels compared to those who are getting a good 7 to 8 hours of sleep every night. Stretching of the stomach after eating is also a trigger for ghrelin release. The 10th cranial nerve, the vagus nerve, it transmits information about gastric distension, calorie content, and hormone release to the brain. Therefore, if the nerve is removed, then we will not have signals going to the brain anymore and would lead to inhibition of ghrelin. Gastric sleeve surgery removes a large portion of the stomach, including the gastric fundus, where ghrelin is made, thus dropping the levels of ghrelin. Prader-Willi syndrome, we will talk about it when we discuss other childhood syndromes, but for now, know that these patients have very high level of ghrelin hormone. CCK stimulates gallbladder contraction and does all the right things for weight loss, such as delaying gastric emptying, reducing appetite, but it has a short half life. Secretion increases with intake of fat, protein, and gastric distension. All right, I'm sure most of you have looked into GLP-1 at some point. For GLP-1, few important things to remember. It delays gastric emptying, thus causing satiety. But as a result of that, it also causes some acid reflux symptoms as a side effect. Patients with diabetes have high glucagon levels, and GLP-1 suppresses glucagon and thus reduces hepatic gluconeogenesis. DPP-4 inhibitors, in theory, can increase GLP-1 levels. However, studies have not shown any additive benefit of weight loss. Therefore, they are not recommended to use together for weight loss. GLP-1 levels increase after bypass surgery. The impact of bariatric surgery on peripheral hormones is something the boards like to test. I'll be making a separate video on that where I'll discuss that in detail. Oxyntomodulin is co-secreted with GLP-1 and does many things that GLP-1 does. There are currently drugs in the pipeline that are OXM analogs, So, this is something you may start hearing about in the coming months to years. PYY is rapidly cleaved by DPP4 into its active form, which subsequently acts on neuropeptide Y receptor. Previous drug trials have used a nasal PYY agonist, but that did not do so well. But there are now ongoing clinical trials for subcute form. So, yes, a lot of exciting ongoing research in this area. Pancreatic polypeptide. It's secreted by the PP cells in the pancreas, and it's an important feedback inhibitor of pancreatic secretion after you eat a meal. There are two long-term adiposity signaling hormones, insulin and leptin, and they will be tested one way or the other. Insulin helps with appetite reduction, and as we have all extensively learned in step 1 and step 2, it plays an important role in glucose and protein intake. Amylin is co secreted with insulin. It does a lot of things that GLP-1 does. That is, it reduces appetite, it slows gastric emptying, it suppresses glucagon. As I mentioned before, there are two long term adiposity signaling hormones that control weight, insulin and leptin. Leptin is produced by fat cells and it activates the weight loss pathway in the brain. Leptin levels increase with weight gain and decrease with weight loss. When patients who are not on anti obesity medications, when they lose weight successfully, they report increased hunger. And this has a lot to do with how leptin physiologically impacts the weight gain and weight loss pathways in the brain. We will discuss this in detail in another video lecture. Few conditions to know about related to leptin. Leptin deficiency can cause obesity as leptin acts as a brake on the hunger pathway. And just as you have insulin resistance, you can also have leptin resistance from chronically high levels of leptin. Adiponectin is made by white adipose tissue, just like leptin. It improves insulin sensitivity. It increases with weight loss and it decreases with weight gain. So, these are some of the main hormones, peripheral hormones, that we need to know for the boards.